Hi, my name is Dilan Maciej-Saker, and I'm a resident in internal medicine here at Yale, and I'll be discussing acute kidney injury as part of the Yale20 video lecture series, a topic that I've put together with Dr. Randy Luciano, a faculty member within the nephrology department. This video lecture should be associated with a primer on acute kidney injury that should also be available to students. The organization of this video lecture will be similar to others in the series, with our first discussing the 5-minute bedside assessment. First, how sick is my patient? Do they require the intensive care unit? What workup do I need to maximize the patient's care? We will then take a deeper dive into whether or not the patient actually has an AKI and what are some possible etiologies based on the physiology of the nephron and some tools that we have at our disposal. After that, we'll briefly discuss the different treatments on the ward and in the ICU and some effective strategies for preventing this in the future. We'll then provide a potential template on how to write this up and present the case before offering a few helpful links. Although we'll discuss it in more detail soon, an acute kidney injury is generally defined as an abrupt decrease in kidney function leading to the retention of urea, dysregulation of electrolytes, and decrease in urine output. In triaging of a patient with AKI, it's important to determine if he or she needs emergent hemodialysis, a procedure that is typically performed in the ICU whereby a machine is used to physically clear the blood of these deleterious products. One way to remember the indications for emergent hemodialysis is the mnemonic AEIOU, standing for acidemia, electrolyte abnormalities, intoxication, volume overload, and uremia. With this in mind, it might be helpful to take a cursory glance at certain labs prior to seeing the patient, including their bicarbonate and associated anion gap for a metabolic acidosis, hyperkalemia, to evaluate for the most important electrolyte that could be deranged, a urine toxicology for intoxications, and the BUN to creatinine ratio for uremia, although the latter isn't necessarily an indication for emergent hemodialysis. With that in mind, we then move on to the history and physical, where it's really important to ask about questions suggestive of a uremia, like weakness, itching, or electrolyte abnormalities, maybe if there's muscle spasm or volume overload with symptoms like shortness of breath or nausea. Then we can move on to symptoms of the physical exam. Once again, uremia, think about things like pericardial rubs or asterixis with volume overload. Are they having an increased O2 requirement? Are they tachypnic? Do they have crackles? And so on. Next, if we do notice these symptoms and we are starting to get worried, we can do a couple tests at the bedside. This includes an arterial blood cast to get a better idea of their acid-base status. We can also check on an EKG to see if they have the characteristic peaked T waves, as illustrated here, or even more nefarious would be something like a widening QRS. If the patient does meet some of those criteria for emergent hemodialysis, they'll probably be headed to the medical intensive care unit. Should none of these numbers be particularly troubling, the next step is to take a closer look at our patient to see whether or not they should be on the floors or even stable enough for outpatient treatment. Now that we're not worried about our patient immediately needing a higher level of care, our first question we ask is whether this is even truly an AKI. So let's take a brief step back and talk about some renal physiology. So you'll remember that kidneys generally function in excreting metabolic waste products and adjusting to the excretion of water and electrolytes accordingly. So blood begins by being filtered at the glomerulus. Then it moves on to the Bowman's capsule. After that's filtered through before passing to the proximal tubule, the loop of Henle, distal convoluted tubule, the collecting duct, and eventually to the ureter before being passed out in the urine. True kidney function is best illustrated by glomerular filtration rate, which is governed by illustrative forces of hydrostatic and oncotic pressure in the glomerulus and the Bowman's capsule. Unfortunately, there is no perfect way to measure this in real time. The calculation for GFR is generally urine concentration times urine flow divided by a plasma concentration marker. Granted, the ideal filtration marker is a solute that is freely filtered at the glomerulus, non-toxic, and this one's important, neither secreted nor absorbed by the kidney, something that's not readily available. Instead, we can estimate the GFR or with creatinine clearance or various equations like the MDRD, standing for modification of diet and renal disease, the Cockcroft-Gault, or the CKD-EPI equations. So what are some limitations of creatinine? We know that creatinine is a breakdown product of creatinine phosphate in muscle, which is typically produced at a regular rate by the body and filtered by the kidneys. However, there are several key limitations to keep in mind. In production, serum creatinine is affected by patients' dietary intake. In addition, it's also affected by their muscle mass, for example, older and female patients producing less. It is also affected by muscle breakdown in states like rhabdomyolysis. Creatinine can be diluted in certain baseline edematous states like cirrhosis, heart failure, or nephrotic syndrome. Creatinine is also secreted at the proximal tubule with medications like Bactrim and H2 blockers like cimetidine affecting it. Another limitation of using creatinine to calculate the GFR or as a standalone value is that at the onset of an AKI, the true GFR will actually drop rapidly to a nadir before eventually the creatinine rises to a steady state. For those reasons, it's incredibly important to identify a baseline creatinine for our patient. Ideally, this can be calculated from mean outpatient values or discharge from a recent hospitalization, although this can be limited by a patient's contact with the healthcare system. Keep in mind that the older a creatinine is, the less likely it is to affect true baseline kidney function. And while there's no perfect measure for AKI, multivariate analyses have shown that a rise in creatinine of 0.3 milligrams per deciliter has independently been shown to have up to a 4-fold increase in hospital mortality. So remember, 0.3 can increase by 4 times. With this in mind, there have been several attempts to create a unifying definition using both creatinine and urine output, including the RIFLE criteria, standing for risk, injury, failure, loss, and ESRD, the AKIN, Acute Kidney Injury Network classification, and now the recent Kidney Disease Improving Global Outcomes guidelines that have merged to do the two. In the KDIGO guidelines, acute kidney injury breaks down with stages 1 being a rise of the 0.3 that we mentioned within 48 hours, or 50 to 99% within a baseline of 7 days, or a urine output that is less than 0.5 milliliters per kilogram per hour for more than 6 hours. However, these other stages are only or primarily used for research purposes, so are not something that you really need to know about. Okay, so we know that our patient has an acute kidney injury, and it's important to keep a broad differential. Creating a differential can be grouped into 3 familiar categories, including pre-renal, intrarenal, and post-renal etiologies. Pre-renal causes can include poor PO intake, diuresis, CHF, vasodilatation, with the general idea being decreased renal blood flow. The mechanism of post-renal injury is through urinary obstruction, leading to hydronephrosis of the kidney parenchyma and eventual reversal of those Starling forces we had mentioned of glomerular filtration. Sources of obstruction can be tubular in the form of crystals, ureteral in the form of cancer or calculi, bladder neck in the form of BPH, or urethral in the form of a Foley or retroperitoneal fibrosis, although it's important to note that this obstruction must be bilateral. Intrarenal causes include acute tubular necrosis secondary to ischemia or infection, interstitial injury, for example, acute interstitial nephritis due to a medication of sorts. Others include crystal nephropathy, thrombotic microangiography, and malignant hypertension. Finally, glomerular causes are extremely rare causes of AKI, which can be nephritic or nephrotic. So now the detective work begins, and the importance of a history and physical cannot be overstated. In addition to clarifying chronic diseases like diabetes and cirrhosis, it's also important to obtain pre-hospital medication lists like antibiotics, but also over-the-counter medications like NSAIDs. Even within the hospital course itself, it's important to be mindful of the medications that were administered, and when evaluating for hypotension intraprocedurally, it's also important to think of other possible exposures the patients might have had, including things like contrast administration for imaging. As previously mentioned, sometimes there aren't many symptoms specific to acute kidney injury, although symptoms like fatigue, nausea, oliguria could be examples of a worsening AKI. On physical exam, it's helpful to check for hypotension and tachycardia within the vitals, especially if supine and afebrile, as that can suggest intravascular volume loss. We can then think of examples on the physical exam that might be suggestive of hypotension, from dry axilla to dry mucous membranes to abnormal skin turgor, and we have some likelihood ratios right there that can kind of predict how much they would help us in determining the patient's volume status. Because by the same token, a patient might also be hypervolemic, and we might want to check for signs that include JVD, S3s, or rails on exam too. Finally, we want to think about those patients who might be having an AIN, an intrinsic injury, possibly secondary to a medication, and we might expect to see things like a rash, or if it's a patient who had maybe a catheterization, they could develop livedo-reticularis from some cholesterol emboli, if that's possible. And then, of course, for those patients who might be having a post-renal etiology, it never hurts to grab a bladder scan and check to see if there's a lot of volume, and maybe even placing a Foley to see if there's anything that can be relieved. When it comes to labs, we can use several values to differentiate between pre-renal, intrarenal, and post-renal etiologies, and in this situation we're going to be very mindful of the differences between glomerular, tubular, and interstitial intrarenal injury. Some of these values can include the previously mentioned BUN to creatinine ratio and urine osmoles, and then we can also look at the fractional excretion of sodium, which is based on the urine sodium in this equation that we have right here. So, how do we use these values? So in general, the idea is that based on where the injury is to the kidney, different quantities of fluids and solutes will be absorbed. For example, the pre-renal patient typically has well-functioning kidneys, which is why the BUN to creatinine ratio is high, as the kidney tries to retain that sodium and that volume whenever possible, which is also why that fractional excretion of sodium is going to be low. On the other hand, in intrarenal injury, the nephron has difficulty retaining fluid, especially with damaged tubules or interstitium, which is why the BUN to creatinine ratio is going to be low, as you can see, only around 10. Conversely, especially in the tubular injury, you're going to expect to see the phenas being a little bit higher, greater than 2 in these cases. However, this can be difficult to predict in our patients with glomerular injury as well. Next, we move on to our post-renal patients, and this, in addition, is also tricky because they might initially start as what appears to be a pre-renal state, which is why they're going to have a BUN to creatinine greater than 20 initially, and they might have a low urine sodium to start off with. But as the kidney gets more obstructed and we start to see more hydronephrosis, this can turn into actually an intrinsic type of injury, and then we can see these values tilt to more that intrinsic type of picture. Another thing that we can do that isn't used very often in the diagnosis of AKI is that of urine microscopy. Especially when performed by skilled operators, this can be low cost, non-invasive, and it's one of the few tests that we do in all of medicine that can actually see inside of the body without putting a needle into it. Things that we can see include red blood cells, white blood cells, and epithelial cells. We can then see casts, which are cylindrical structures composed of proteins and are generated in the distal convoluted tubule and the collecting ducts based on different disease states. These include hyaline casts, these faint casts that you see here that are associated with or that are composed of TAM horsefall protein and are translucent. The TAM horsefall protein is actually in all of these casts about what other structures are involved in it as well. For example, you can have red blood cell casts, which are rare, but they could be indicative of glomerular damage from glomerulonephritis. You can also see renal tubular epithelial casts, which are displayed here, or granular casts, which can occur from the breakdown of tubular cells and plasma proteins, which can be predictive of an acute tubular necrosis. Then we can move on to some of these white blood cell casts, which are rare and can be indicative of inflammation or interstitial disease like pyelonephritis or AIN. Crystals are another thing we can see, as illustrated by these calcium oxalate crystals and uric acid crystals here. So how do we put this together? Well, in pre-renal states, we would expect the urine to be bland and maybe having some hyaline casts. In intrinsic injury, this can be really helpful because we can specify what type. So while I mentioned the red blood cell casts, and these can be rare, we're more likely to see RBCs, red blood cells, in glomerular injury, specifically dysmorphic ones called acanthocytes. In tubular injury, we can see these granular casts that we mentioned earlier, in addition to the renal tubular epithelial casts, which are really important because, as you can see in this diagram, the number of granular casts can be really predictive of whether the patient has ATN or not. If they're having greater than 6 to 10, you can have a likelihood ratio of up to 10. Next, we can see our patients with a possible interstitial injury if they have white blood cell casts, but just like glomerular injury, it's going to be the white blood cells that are really predictive, and you're rarely, if ever, going to see eosinophils. Finally, in our post-renal patients, their urine's either going to be bland, or we can see some of these crystals if they have something like nephrolithiasis, or red blood cells possibly if they have something like a cancer that's obstructing. Finally, some other imaging studies we can perform include a bladder scan to evaluate for urinary retention and a renal ultrasound to evaluate for nephrolithiasis or other forms of obstruction. A biopsy, only if we can't use those measures to find a diagnosis, can be used to give us a better picture. As is always the case, as tissue is the best diagnosis.